But I wanted to ask a question first of all, simply about how far the NHS has ever been sustainable in terms of this country's own resources. I mean, I'm thinking back to the phenomenon of the Indian doctor in the 1960s, for example. Hasn't Britain, has Britain ever had a sustainable workforce for the NHS?
So, no. And the large reason for that is that we've been seeing a consistently falling birth rate over the last couple of decades. So what this has caused is that, yes, while some of the metrics have gone up, and we do have more nurses and more doctors than we ever have had, we don't have enough of those people who were actually born in the UK to train up. We're facing quite a big crisis when it comes to the aging population. I think I mentioned it a few times that our 65 plus cohort take up approximately 80% of our resources at the moment. And that is something that we should have been planning for from the 1980s. But the birth rate just hasn't ever been there. It comes from the fact that we did have a major population boom in the mid-century, and that is now starting to trail off. And it's a fantastic, amazing thing that people are now living longer. But with the birth rate that has fallen so significantly, I think the latest birth rate statistic is that we're at 1.4 births per woman, and it should be at 2.1 to sustain our population. And we just don't have that ability, and we haven't had that for many, many years. So we would have always been dependent on an international workforce based on the certain set of circumstances that we have found ourselves in.
That kind of reinforces your point that what Brexit has done is amplify problems that were already there in the system, but in a particularly chaotic kind of way. One question is whether there's been much impact on the NHS of disenchanted staff leaving for more lucratively rewarded work in other countries, such as the Emirates.
So, yes, though the main location isn't really the Emirates, it's Australia. It's Australia, New Zealand, and Canada. So, yes, we are seeing quite a few of our staff who are heading off to places that they do earn more, where they can work less, and where they generally have more training opportunities. One of the issues is as well is that our training opportunities within the UK are unfortunately being eroded. They've not kept up to pace with our needs. So I think there are only about 11,000 training opportunities or so. Correct me if I'm wrong in the number, but there is a significant shortage of especially consultant training opportunities. So what we find happens is that our locally trained doctors, our foundation year one, foundation year two doctors who are looking to go into a specialty or to core training or to further training don't necessarily get those spaces. And while they can work in the system as sort of a normal non-training doctor, the pay isn't particularly good. The work is long and hard, and there's no sort of long-term plan there. So what is happening is we are seeing quite a few of them go to sunnier shores. I haven't heard that it has been the Emirates very much, but anecdotally, Australia, New Zealand, Canada, very much so.
One question I had was you made a point about the NHS not benefiting from price discounts so much post Brexit. I wondered if you could unpack that a bit. Why is that so?
So essentially, it's our trading value. It's because we're not connected into the EU trading market anymore. So there's more disruption for getting medicines in. So many of our manufacturers sit in the European Union. So where we are now is that trade cost is increasing, that friction is increasing from both sides, which means that there is an additional cost now on top of what we would always negotiate in terms of our discount. Like I say, this is not something that is necessarily unique to the UK, and we have seen policy changes in the United States that have severely affected us as well. The most glaring example is the cost of the weight loss drug Mounjaro, which has increased from, I think it was £89 wholesale to about £330 wholesale. based on United States policies. Now, that has a broader impact on where everything else goes. So it's all this market instability, which the EU, because it's such a big market and has so many of its own manufacturers, can carry a lot better than we can do in isolation.
Again, a question in the chat, a comment really, but about how lack of continuity affects dietitians and also pain relief for long-term or non-survival conditions, particularly in terms of changing from one morphine drug to another.
It's an exceptionally valid point. I think care has become very helpfully, very personalized. But that personalization also comes with your practitioner knowing who you are and how you react. So with this rotating that we have been seeing in community staff and with the faces changing, there is a bigger reliance on good handovers. There's a bigger reliance on building relationships again and getting to know your patients again. A patient is not just a set of symptoms. They're a whole human being. So your patient who may have done well on their pain medication during a time of low stress or during a time where it's warmer or colder may not be doing so well in another period of time. So that continuity breakdown that we're seeing means that patients, those things need to be relearned by our practitioners. And it does, unfortunately, as I say, the people who carry the impact of this is definitely patients, unfortunately.